Dr. Roger Owen is a consultant haematologist at Leeds Teaching Hospital, so he has a long-standing interest in laboratory diagnosis and response evaluation in myeloma and related disorders. And in fact, Roger first started working on MRD in 1994, so the ideal person to update us on flow cytometry.
Yes, thank you, Jennifer, for reminding me how old I am. I know that every morning I wake up. So thanks very much for the invitation. I have quick disclosures. So much of our work and early work was funded by Celgene, now BMS, and without that we wouldn't have generated a lot of our data. And apologies to Hannah and to Mark, who I see in the audience. I've had a long-held prejudice against serological methods, and maybe I should change my mind now having heard your talk. In terms of using this for clinical management, I've become an increasingly conservative clinician. I'm certainly nervous, certainly in the context of stopping therapy. And I wasn't entirely sure what Jennifer and Ramter asked me to do, and I apologise because I may stray off my brief. So, as Jennifer mentioned, Andy Rawstron and I started getting into this in the mid-1990s, and it was a very limited stuff that we were doing then, and this is the first paper that we demonstrated any outcome influence of MRD. So this was day 100 bone marrows from patients in myeloma 7, for those of you who can remember that far back. And indeed, this was first published in 2002. So we've known about the prognostic significance of MRD, certainly in the post-transplant setting, for 20 plus years. So just a quick review about how flow cytometry works. So flow cytometry works because myeloma plasma cells have a number of significant phenotypic differences with normal plasma cells, and that allows us to distinguish between myeloma plasma cells and normal plasma cells, which is important in the post-treatment setting when we are hopefully regenerating normal plasma cells. And this is, and we use a very simple test that hasn't really changed very much over many years. It's a single tube, 8 colours, and you can see here this is the myeloma plasma cells are orange, so they typically have weak CD19, but they can express CD56, CD117, have weak CD45, for instance. What we know from historical data is that if you have an aberrant and myeloma-like immunophenotype, those cells are by definition monotypic. The plasma cells in other disorders and other B-cell disorders, Waldenstrom's, for instance, do not have this phenotype and cannot be followed in this way. So as I mentioned, we have a single tube, and we use this across all our diagnostic situations. So in the diagnostic setting, we'd be looking at acquiring 200,000 events in the diagnostic setting. But in the post-treatment MRD setting, we're looking at getting between 2 and 2.5 million leukocytes so that we hit the IMWG recommended limit of detection of 0.001% or 10 to the minus 5. So our use of flow has evolved over time, and we're all for simplicity, so we're using the same test in the diagnostic setting. So there are a whole range of clinical scenarios where this methodology can be helpful. Amyloid, patients with plasmacytomas, patients with funny diseases like IgM myeloma or IgG Waldenstrom's, for instance, and patients with NGRS. So it has significant diagnostic utility in addition to the response assessment utility. And we had an interesting discussion in the taxi on the way over about how one should use flow cytometry in myeloma, and I would suggest that we should be doing it in all cases of suspected myeloma, because demonstrating an aberrant phenotype, is effectively demonstrating monotypic plasma cells. And actually, for us, it saves time and it saves money, because if we're using flow cytometry systematically, then we are much less reliant on IHC, on the trifine biopsies, to make a diagnosis. So most of our myeloma MGUS diagnoses on a bone marrow do not require any IHC. Those that do just need a CD138 to clarify the extent of infiltration, and a very small minority will require a full, more extended panel. So I think the systematic use of flow in this setting is actually a cost-efficient thing. So what do we know about MRD and myeloma? This probably tells you everything you need to know, really. This is the meta-analysis from 2020, I believe, from Nikhil Munshi and colleagues, and this shows the impact of MRD. If we look on this left-hand side, so this looks at transplants at newly diagnosed, transplant eligible, ineligible, and relapse refractory. You can see there's a significant impact on PFS and also OS, which is more pronounced in the relapse refractory setting, obviously, as these patients are less likely to be salvaged. If we're then looking at other factors, so sensitivity does have an impact, but even with relatively low sensitive methods, you're still getting a significant impact. Greater impact of sensitivity improves, but this is applicable to all biological risks. It doesn't really matter what method you do, whether this is flow-based, PCR-based, standard ASO PCR, or next-generation sequencing. It doesn't matter whether you're in the CR or not. So we can see here that it's applicable across all patient groups, regardless of biological risk. So this is a kind of definitive statement about at least the prognostic utility of MRD. The other thing that we need to mention is that MRD is about measuring levels of disease and not just determining whether it's present or absent. And there is an effect, and this is NGS-based data here, but we've got similar data with flow, and you can see that your levels of disease have a significant impact on your outcome. Certainly in myeloma 9, we demonstrated that there was probably about a 1-year overall survival benefit for each log reduction of disease. The other thing to notice, particularly in the context of trials, is that the difference in outcomes for patients with very good responses does take a long time to show itself. So the difference between negative at 10 to the minus 6 and positive at 10 to the minus 5 probably doesn't show itself for about 3 years. So how has all this panned out in a regulatory sense? And this is about almost a year ago now, the FDA finally approved MRD as an outcome that was reasonably likely to predict clinical benefit. So this is not a true surrogate of outcome. This is something that would then lead to intermediate approval pending proof of benefit with standard measures in the fullness of time. So this process came about by 2 really very major pieces of work. There's the I2 team consortium led by Nikhil Munshi and the evidence group from Miami led by Ola Landgren, and they had independent submissions to the FDA, which then led to this approval and unanimous approval of the potential to use this as an endpoint in clinical trials. So what are the advantages of flow? Well, I think applicability is very good. So probably at least 98% of patients will be informative using flow cytometry. There'll be a small proportion of patients who do not have a phenotype we can follow by flow. That will be less than 1%. And there will be some patients in whom they are not informative because they've got patchy marrow disease at presentation and we're simply not sampling it. Quantitation, as I hopefully demonstrated, quantitation is important. And in the context of flow cytometry, this is direct quantitation, so we're actually counting cells. So that's easy for old brains like mine to work out rather than the complex bioinformatic computational way that the NGS do it. Limit of detection at the IMWG threshold, probably achieve that in around about 90% of patients. Kind of depends on the setting. If you're certainly doing trials and you're wanting to do other things with your post-treatment marrows, then that will fall. But if you're just doing a bone marrow for your response assessment, then we will hit that threshold at least 90% of the time. You obviously do need a fresh sample, so that may in certain circumstances be an issue. We don't have an obligate requirement for a presentation sample, but it's useful to have. You can potentially produce the results in real time. It's relatively inexpensive. And as I mentioned before, this is something we can use for a range of other things too. So just a slight word of caution here, and that is how there can be differences between methodologies, and this is a study that looked at the difference between flow cytometry and an NGS-based method. This was the lymphotract method rather than the clonoSEQ, but you can see that there are patients that can be positive by NGS but negative by flow, and also cases that are vice versa. And this will always be the case if you're comparing methods. The other thing to note is actually there can be a difference in the levels of disease as well. So if you look here, this is where the flow is overestimating compared to the mean, and the NGS is overestimating compared to the mean. So there can be, as well as a discrepancy in the qualitative answer, there can also be a discrepancy in the quantitative answer. And this can also be the case even if you're using the same method. And this is data that Andy Rawson gave me from a CLL initiative that they are doing. And this is where they distributed some flow cytometry files to 10 laboratories and asked them to quantitate the levels of disease. And you can see that if we were to look at the simple positive or negative, we would see that there is concordance between labs about 80% of the time. And this is at the IWCLL threshold, which is a log less than the myeloma threshold. And this is just looking at flow files. This doesn't take into account any differences that might occur through differences in practices during the wet part of the process. And similarly, if you look at the concordance of levels of disease, you will see again that there is some discordance in terms of people and their quantitation, and that typically occurs at the lower end of the levels of disease, so clearly essentially at the business end of the assay. So I'd like to conclude, and based on my previous prejudices, I think we're probably still looking at cellular-based methods in the bone marrow as the gold standard here. In terms of what's available, we can look at flow cytometry or NGS-based methods. They're both applicable. They're both, in a sense, you pay your money and takes your choice. They are both highly applicable. They both have a very solid evidence base behind them. But I think we should have some caution that in terms of when we're thinking about routine use here and in terms of potentially altering therapies in the routine setting, is that there will always be discrepancy between methods. and even between labs when they're using the same methods, particularly at the low levels of disease burden. So where are we with MRD? Prognostic factor, I think we can all agree that the evidence there is overwhelming. We now have final approval from the FDA that this might be something sensible to use in a registration clinical trial context. And I guess the jury still is out in terms of its applicability in the routine setting, and there are obviously a whole range of local factors that can influence how we do that. So I'll stop there, and thanks for your attention.
Thank you, Roger, for the fantastic presentation. Can we please keep the questions for the panel discussion? And